Hello and welcome to Talking Meds, a podcast from PrescQIPP, engaging conversations about medicines-related dilemmas. I'm your host, Jonathan Underhill, Medicine's Clinical Advisor here at PrescQIPP. Hello and welcome to the final episode of Talking Meds for 2025. I hope we've had a good year, although I expect it's been rather tricky for many of you with the ongoing uncertainty around the NHS restructure. I guess let's hope 2026 can give us some stability and certainty, but I wouldn't be holding my breath. This is the NHS after all. We've had a really successful year here at PrescQIPP, and in particular with the Talking Meds podcast. This will be our 34th episode of Talking Meds, and bear in mind that most podcasts only last about 3 months before they stop. I think that's actually quite a success story. We've had over 13,000 downloads of the podcast since we started. So a big thanks to all of you for listening, giving us your suggestions and your feedback, and please keep that coming. Of course, that's largely down to the wonderful guests that we've had on Talking Meds, that I've had the privilege of talking to. So on that note, for our final episode of the year, what we've done is we've invited back 3 of our former guests to talk about their sort of retrospective views of what's happened in 2025. So first of all, I'm joined by Professor Adam Todd. Adam joined us back in July 25, where we discussed his work on how community pharmacy can buck the inverse care law. If you remember, the inverse care law is where those people who most need to seek healthcare assistance are those least likely to do so. And Adam's done quite a lot of work on how community pharmacy can buck that. You'll remember Adam's a professor of pharmaceutical public health and the deputy head of the School of Pharmacy in Newcastle. I'm also joined by Dr. Deb Gompertz. Deb joined us in June 2025, where she talked about her wonderful Show Me Your Medicines campaign. I know you're not supposed to have a favourite episode, a bit like you're not supposed to have a favourite child. But I have to say that was one of my favourite episodes. What a wonderful project it was. And if you haven't listened to that episode, it's definitely worth doing that. You remember Deb as a complex care GP within the south part of Somerset. So delighted to be joined by Deb. And last but by no means least is the soon-to-be doctor, Hadeel Mohammed, I hope. Because Hadeel is just in the throes of finishing her PhD. So hopefully she's going to be a doctor soon as well. You'll remember Hadeel joined us in March 25 for episode 14, talking about the importance of mentoring and how that's really helped her and helped other people, and how she's set up the ENIGMA campaign to try and encourage mentorship for women from ethnic minority backgrounds. Welcome to all of you. Thanks for joining. And yeah, so I guess let's go to you first, Hadeel, if we can, if that's all right. So what have you been up to since we last spoke back in March then?
It's been a really busy year. So like you said, I'm just at the end of my PhD, so it was very much about getting that thesis over the line. So I thankfully submitted at the end of October, and actually most recently I've then been preparing for my Viva, which is in 10 days' time. Not that I'm counting. So this year was very much about doing that, but also then sharing my work. So I've spent quite a bit of time kind of going to different places, so academic conferences, but also like professional networks and meetings, and trying to share what I found. And it's been really interesting actually to see how different audiences kind of like have taken the findings of my work and interpreted them and how useful they found them. So that's been really good. And then obviously, like you said, I've been working on ENIGMA. So amongst all of that, ENIGMA continues, and it's actually now in its 3rd cohort, which feels like crazy that it's been now in 3 years. But this year has felt different. It feels like it's really flourished, and I feel like there's been a lot of momentum. Lots of people wanting to get more involved, mentors and mentees. So that's been fantastic. I think that the community kind of feel in ENIGMA has definitely grown this year as well. So a lot more engagement and support between mentors and mentees. So seeing that impact has been really lovely. But amongst that, I'm like lots of other things as well, but they were the key things, and it's been busy but very rewarding. So
fantastic. There's one thing you haven't mentioned, Hadeel, isn't there? And I know you're too modest to say this, but I think quite recently, you were awarded the Rising Star Award by our friends at the PCPA, were you not?
Yeah, yes, that as well. Yeah.
Yes, and I have to say, I think that's very, very well deserved. As you say, you've worked really hard, and it's really nice sometimes to be recognised by your peers. And it's important to celebrate that, and you should certainly take a bow about that for the fantastic work that you've done. So well done from all of us to you for that.
Thank you. Thanks, Jonathan.
Thanks, Hadeel. So Deb, what have you been up to since we last spoke?
Been really, really busy. Any opportunity to talk about show me your meds, I can never resist, and I almost have a little bit of a competition with myself when I'm out at meetings. Who doesn't know about it? Who can I talk to about it? And I suppose in the same vein about talking about wasted medications, the sustainability side to that is really important to me. And at the British Geriatric Society, we've just tried to restart the sustainability group with a new impetus and see where we can go. So I'm really excited about what that's going to show us next year and how I can get involved with that. Lots of community working for me, being a complex care GP. There's all the neighbourhood work going on, shared decision making, person-centred care. So for me, that's about working with multiple team members, pharmacists, pharmacy techs. I seem to constantly have a pharmacy tech or a pharmacist sat in the car with me when I'm going out visiting, which is what I enjoy, really enjoy that. And I suppose the other bit of news from me is that I progressed on to be the Honorary Secretary for the British Geriatric Society and Vice President for Policy, which is also exciting as to the opportunities that will lead to for older people's healthcare.
Fantastic. Congratulations on that then, Dave. I have to say the British Geriatrics Association, I think, is one of those organisations that I've always really been impressed with the work that they do and the collaborative nature of what they do as well. I suspect we'll talk maybe a little bit later on about some of the things that have come out in the BGS that I'm a massive fan of. And there were other sectors who perhaps didn't take as warmly to some of the stuff that we did. But let's talk about that in a minute. So Adam, again, thanks for joining us. What have you been up to since we last spoke?
Yeah, thanks, Jonathan. So it was really nice to listen to Hadeel, who was talking about preparing for a Viva and a PhD. So I've had the pleasure of supervising a number of students who have been successful in their PhD Vivas since we last spoke. So that's been a real privilege and pleasure, particularly because some of those people were pharmacists as well. So it's always nice to support people in pharmacy to go on and into further research. So I've been doing that. And another thing that I've been doing is we had some research, which was led by a PhD student, where we found out about inequalities in access to medicines. And in particular, we looked at new cancer medicines, so things like immunotherapies, tyrosine kinase inhibitors and things. And we found that even in an NHS, that we still see quite significant socioeconomic inequalities in access to those medicines. So that was a PhD student a few years ago now, but we've been successful in securing quite a large grant in exploring that further. So that's really positive and something I'm looking forward to.
Fantastic. I mean, again, some of the work that you've done around that is, and when we talked about that last time, it's just so interesting, but also meaningful. And I think that's the important thing. It's not just academically interesting. It is, but it's not just academically interesting. It's actually really useful for people to do something about health inequalities, which is one of the big sort of items as a priority for the service to do something about. So without having sort of passionate academics like yourself driving some of that, then often you miss the importance of what you can actually do about it. So thanks to you and your team for all of that. So Deb, can I ask you, if we have a look back on 2025 then, what do you think the big thing, the big news items were from 2025 in terms of medicines and prescribing, let's say?
I think for me, the big standout document and piece of work was the pragmatic prescribing document that the British Geriatric Society launched, which was endorsed by the Royal College of General Practitioners, the Royal College of Physicians for London and Edinburgh, Royal Pharmaceutical Society, and NICE also added a comment to it. And that document is really key for community prescribing to look at people with moderate and severe frailty, to give people permission to think differently about shared decision making, person-centered care, getting it right for these older people without and medically optimizing them. So deprescribing, but doing it in the right way, because I know sometimes we don't like to use the word deprescribing. And we've had such positive feedback from so many people where they can use it and use it as a resource. And it's going to be iterative, hopefully. So we're going to have more versions of it. It's just a simple A4 side at the moment that allows us to think differently about what we're doing.
I was going to say, I think the beauty of it is its simplicity in some ways, and the fact that it is just, well, not just, but it's a single sort of document that's really easy to access, really easy to read, but is grounded in pragmatism, as you'd expect, because that's the title of it. And I'm really pleased to see that NICE have endorsed this, because when I worked at NICE, we used to talk long and hard about there are targets in NICE guidance, but they're only aspirational targets. Sometimes, and at the start of every bit of NICE guidance, it says apply this to the individual and their values and preferences and their individual circumstances. So it's different if you're a 55-year-old man with heart failure than an 85-year-old man with heart failure, isn't it? And sometimes people forget that, don't they, Deb?
Absolutely. And I think it's about really having a conversation with a person. And I think we have to get to the core of that, talking to people, seeing what really matters to them, but also understanding that doing nothing is not okay when these people are on multiple medications who may have severe frailty. It's not okay to sometimes leave them on medicines that may cause harm. So it's a sort of a call for action, really, for us to all start thinking differently. And I think as people come up through training, whatever specialty they are, this will help them to see that it's okay. We don't have to follow the guidelines right to the dot for our older population. We can think and we can have these conversations. So it was presented at the conference. It got really good feedback. It's been downloaded loads of times. Lots of people have been presenting on it all over the place. So if you want to find it, it's on the British Geriatric Society website.
Yeah, and we'll put a link to it in the show notes as well, Deb. Don't worry. The other brilliant thing on there is that it talks about BRAN, doesn't it? Benefits, risks, alternatives, and no treatment. A fundamental part of pragmatic prescribing. I also hope this becomes embedded in all undergraduate and postgraduate training programs for healthcare professionals who are prescribing. Wouldn't that be nice?
Yeah, wouldn't that be great?
Yeah, absolutely. Well, brilliant. What a great start. No pressure, guys. But so, Adam, what do you think the big news items were from 2025?
I think there's a few for me. I think one of them is probably around the Pharmacy First scheme and community pharmacy. And I think even though this was started off in 2024, I think it's just really exploded in terms of increasing accessibility to healthcare and medicines. So I think it's really, giving a shout out to all the community pharmacy colleagues there who are doing a fantastic job, and also just how they've really embraced that kind of changing role. And also the fact that I think community pharmacy is now increasingly becoming acknowledged as a clinical profession as well. So I think for me, that's just fantastic and great to see.
Completely agree. I think the evaluation that's been done, so there's an interim evaluation that's been done, I think, and then there's a full evaluation being done by one of the, I think it's the London School of Hygiene and Tropical Medicine are doing the evaluation, aren't they? But again, colleagues at NHS, as I was involved with when we first put Pharmacy First into being, and the amount of work that went into getting the clinical protocols and guidance right was incredible. And I think what we've seen in the last year in particular is the fruits of that work. Like with all these things, sometimes these things take a bit of time to get off the ground, don't they? But I see Pharmacy First in science and community pharmacies now. And that's not an exception anymore. It tends to be most community pharmacies that I see have got the Pharmacy First service being advertised to people. And I know people who've used it, family and friends who've used it, and anecdotally have found it really, really helpful. And the evaluation, the interim evaluation, bears out that, doesn't it?
It does, and I just think it's so important, because I think we've seen sometimes where new services are are developed and delivered, they'll just start off, they won't really work, if you like. It's the implementation of these services is always difficult, and it just kind of tends to fizzle out. Whereas again, I think for Pharmacy First, this year particularly, I think it's really exploded. And I just think that's great. And I suppose as a researcher, I'm interested in how that's particularly impacted on health inequalities research as well. So is it a case of, people who were potentially able to go and, see a GP or a walk-in centre or whatever, have they just used pharmacy as another source of healthcare, which would be fine? But I'm also interested in, actually, are these people who have attended pharmacy wouldn't have reached out to other branches of healthcare? And I think it's a really interesting question.
It is, isn't it? So it's that reducing the workload on other primary care clinicians, GPs in particular, but also, are we also getting the people who wouldn't have gone to see their GP? And that's where the real benefit, I think, for health inequalities is. Because, as we say, community pharmacies are located where health inequalities exist, don't they? They're on your high street, in your estates and all those sorts of things. And other parts of the primary care system perhaps aren't. So, no, I think it's really positive. It'd be really interesting to see what happens with it and how it develops, because obviously there's only 7 conditions at the moment that are part of the Pharmacy First scheme. Who knows how many there could be in 2 or 3 years' time? Hopefully a few more. So no, I think that's a really good point. Hadeel, so what do you think the kind of the big news items were for 2025?
Oh, I can't be asked that question and not mention the 10-year plan. I think it just shook everybody, didn't it? In good ways, and maybe a bit of uncertainty that's come with it, but especially because my clinical role is like general practice, I think we've really felt it. It's positive, and I feel like there are lots of opportunities. It's the right thing that healthcare should be moving more towards prevention and kind of doing what we can in the primary care setting. But I think there is a bit of, not maybe concern, and uncertainty is probably the best word, amongst especially pharmacy staff. While on paper it feels like, are they trying to say there'll be more opportunities and more roles? But at the moment, we don't really know what that means and what it translates into in a practical sense. And the neighbourhood teams, a lot of people are trying to get the pharmacy seat on the table, and it's not that easy even now. So trying to make sure that we are at the table when decisions are made, so that when the neighbourhood teams are formed, pharmacy really does have the influence that it should have, definitely. Because you can't, like, medicines are a huge part of a patient's healthcare journey, aren't they? So we need to be part of that. So I'm hopeful and thinking that it will bring with it lots of opportunities. That's how I'm choosing to look at it.
Yeah, I mean, when the 10-year plan came out, like many, I had a look at it and thought, well, there's not much here I disagree with in terms of the aspirations and the vision. But at the time, I remember having conversations with colleagues and friends saying, well, how are we going to do this? Where's the operational plan for how we're going to actually do this? And I think we're still waiting for that, aren't we? So maybe looking ahead to 2026, we might see this bearing some fruit and actually coming into operation. And I think you're also right. There's always going to be uncertainty and pain around this, but potentially really, really positive things for the future. I mean, the shifts from secondary care into primary care, but obviously that needs to be accompanied by proper resources and doing it properly, and some difficult, uncomfortable decisions.
Yeah, exactly.
Around hospitals and services that are delivered traditionally in hospitals that perhaps aren't anymore. And of course, that probably means that you're going to have to stop some services being delivered from hospital. And of course, that then becomes a political thing, doesn't it? Because no one wants their local hospital to close. Somebody else's hospital can close, that's fine, but not mine.
Not mine. But there's something else about the fact that, because a lot of my research was based on the hospital to home transition, and it really highlighted what we know already, but even further, the lack of communication, the poor communication, the lack of integration across systems and the ways that we work. So it's hard to see all of those things need to be addressed first in order for this to really work, because there's going to need to be really good communication in both directions in order for us to truly have that and those services to change. So I'm hopeful.
Yes, hopeful is a good place to be, Hadeel. And let's wait and see. So just to sort of like think about 2025 in another way, what do you think the big thing that happened that you think people might have missed? Adam, can I go to you first for that one?
Yeah, of course you can. So, you know, I'd like to talk about research again if I can. So I think we've spoke about community pharmacy again, community pharmacy accessibility, and I think last time I was on, I spoke about the research we've done around community pharmacy access going against the positive pharmacy care law, and again we did an update on that was published a few months ago that showed that actually the accessibility is still there. So despite challenges around funding and instability in the sector, and a number of pharmacies closing, we still see the community pharmacy or the positive pharmacy care law in place even now. And I think we published that, and certainly when we published the first paper back in 2014, that went national. Everybody was very interested in it, and it was great. And we kind of published the update, and although people were interested, it just kind of went under the radar a little bit. So I think just to highlight that, I think.
Yeah, it's interesting, isn't it? Good news days are important when you're publishing research, don't they? I remember working at the National Prescribing Centre, and Professor Neil Maskery and I did some work looking at diclofenac, and we looked at the MHRA warning about the increased cardiovascular risk of diclofenac, did a back of the envelope calculation, and we reckon there's about 2,000 excess deaths, or sorry, not deaths, but cardiovascular events due to the prescribing of diclofenac. And we thought, oh, crikey, we need to be careful about this in terms of the press release and how we launch it. So I remember Neil saying he got all ready for it, got his suit and tie ready for the media interviews. And on the day that it came out, it was the story about Canoe Man, the man who'd faked his own death. And that was all over the news. Everything else got drowned out. Now, so I suspect that's maybe what's happened with sometimes that happens with research, Adam. You just get unlucky if there's a big news item in healthcare, it doesn't get publicised.
No, 100%, 100%. I think it's just one of those things, and it depends what the news is. And again, I've had experience of having things lined up to talk about various aspects of research, and then you get a kind of a phone call or a text message at the last minute saying you've been bumped onto something else. Either Newcastle signed a new forward or something, and that's more important than the research, which is fair enough.
Well, you'd take that, wouldn't you? I certainly would. So yeah, very good. Okay, Deb. What big thing do you think maybe we went under the radar a bit, or we missed in 2025?
Well, it probably hasn't gone under the radar, but I think the thing for me is, along with the 10-year plan, the population is ageing, and our population of over 80s is going to double, I think, in the next 20 years, we're estimating. So there's another document, sorry, I'm going to talk a lot about documents from the British Geriatric Society called the Core 20+5 for older adults, older people. And we've got one for adults and we've got one for younger people. So this is to highlight the health inequalities, and we've talked a little bit about that already. So it highlights the geography, the core 20 plus in the most deprived areas, so helps us to sort of target our thinking. It then allows us to think about a smaller group that our ICBs, ICSs might want to tackle, and then comes up with 5 clinical areas that we can then measure our progress on and help us align our thinking. And for neighbourhoods, this has been really helpful to help them to segment populations so that they know where to start with frailty identification. So the 5 areas of frailty, dementia, falls, we've got long-term conditions and polypharmacy, and then advanced care planning, end of life. So that is a tool, and it's got some metrics on it that I think people may find useful. And then it's last year, and I know it will go into next year as well, but it's one not to miss with the change of the year, I think.
Yeah, brilliant. I mean, I remember someone said to me in 1945, 1946, 1947, when there was the baby boom, when there was lots of, those people are 85, 86 this year, aren't they?
Yeah.
And that's why we're seeing this kind of massive increase in that particular demographic. And as you say, that comes with potentially increased frailty, increased problematic polypharmacy, and the need for us to be careful.
And prevention, and which all goes with a 10-year plan and keeping fit. And maybe there's something about us all thinking about what we should be doing for ourselves now. It's never too late, is it?
It's never too late, absolutely. Again, I've got Lucy Pollock in my ear talking about that very thing. So yeah, absolutely. Okay, so let's have a little. So we've looked back on 2025. Let's try and be a bit, I don't know, looking forward to 2026. So if I can go to each of you and say to you, if you could wish for one thing to change in 2026, what would it be and why? And Adam, I'll go to you first. And obviously, Newcastle winning another cup would be one thing that both of us would certainly sign up to. But apart from that, what else would you like to see in 2026?
So if it's not football related, I think for me this year, and again previous years, have been quite there's been a lot of instability in various sectors, whether or not that being primary care, community pharmacy, or even when I work in higher education. So I think I would really like to see just more stability for people to really focus on planning for various tasks, projects, more stability, I think.
Yeah, there's, as we said at the start, there's lots of uncertainty out there at the moment. There is, at least in the last few weeks and months, been a little bit more certainty around what's happening. I suspect 2026, this time next year, there'll be a lot more clarity, and people will have gone through the painful process of whether it's voluntary redundancy or whatever, and have found something else to do. But we shouldn't underestimate the toll that takes on people as individuals, and indeed, people workforces as well. So it's great having ambition, and the 10-year plan is ambitious, but there also we need to look after each other and look after people who are going through this. So yeah, I think that's a really, really good point. Hadeel, what about you in terms of if you had one thing to wish for in 2026?
There's far too many things that I'd like to wish for, but I think relating to my research, I'd really like to see a start in medication, how older people actually manage their medicines when they are discharged from hospital, and in that post-discharge period being explicitly considered before things go wrong. So before a patient is discharged, early on in the discharge planning, for it to be a consideration that we assess and we check that with patients, with the people that support them at home, so that when they go home, those avoidable errors that happen and bring people back into hospital and lead to harm then are actually prevented. So for me, obviously that won't be fixed in a year, but if I could, get that going and kind of put the findings into action, just to start with, that would be great.
Yeah, I mean, it plays to what Deb was saying about the pragmatic prescribing work that the British Geriatric Society did. It's that sort of failure demand, that not sorting it out or spending time trying to make things a bit less complex for our frailer elderly people. It's that time is well spent, because if you don't do that, as you say, admission to hospital can be a disaster on an individual basis, but also for a population as well. So there's definitely something there for me there, I think, in terms of people giving that due respect and due attention. Deb, can I come to you? Last but not least, of course.
I think I'd like to see a renewed focus on sustainability and reducing waste, whether that's medicines waste in the system because we're duplicating with our services, waste, in all sorts of ways that is meaningful to people working on the ground. Because I think if it's meaningful, we get value out of making changes for people, patients, our systems, our services. And I think that adds value to everybody's lives. And I think we need to just highlight, what changes are happening with the planet again, really. And I know that might sound over dramatic, but we have to sort of make it a bit dramatic so that people want to change, don't we?
Yeah, you do. It's interesting. These things, I think, come in cycles, don't they? A few years ago, sustainability was on everyone's agenda and was
Absolutely
top of the shot priority. And I think you might be right. I think that might have slipped down our priorities a little bit. But we mustn't forget that. And I'm always minded when we interviewed Mina E about sustainability and greener pharmacy. The hallmarks of good medicines optimization and person-centered care. If you do that well, then that decreases the sustainability impact, because a medicine that's not wanted and not used is the one that is least sustainable and has the biggest impact on the environment. So yeah, let's not forget about that, eh? And our politicians need to help us with this as well, because I do think there's a little bit of becoming a bit glib about sustainability, and it's been seen as being, I hate this word, but it's seen as being a bit woke.
Yes, exactly. Yeah.
And it's not. It's really, really important. It's really, really important. So no, thanks for that. Thank you to all three of you. Hopefully that's been a fairly light-hearted, retrospective sort of wrap-up of the year in medicines and prescribing. I'd just like to say to all our listeners and all the guests that we've had on, thank you so much. Thank you so much for listening. Thank you so much to the guests for participating in what I think has been one of the most enjoyable things I've done in my career, which is interviewing really, really smart, intelligent people and letting them do the talking. It's a bit of a sort of a, because I like to talk, you've probably noticed this. So it's good for me just to ask questions and sit back and listen. It's a good skill for me to sort of practice as well. But no, thanks very much to you all, and we'll see you in 2026 for more Talking Meds. Thank you. Merry Christmas. We hope you enjoyed today's podcast, and we'll see you in a couple of weeks for the next episode of Talking Meds from PrescQIPP, engaging conversations about medicines-related dilemmas. Please follow us on LinkedIn and Blue Sky to join in with the discussions, and email us on talkingmeds@prescript.info with your feedback or suggestions for future topics or guests. Please don't forget to register for access to the PrescQIPP website for all of our excellent resources.